So, hello students, welcome you all into the part 2 of the anti-thyroid agents here. We will discuss about anti-thyroid agents here, which we call it as thyroid inhibitors. If you see this particular diagram, you can find there are 4 places, so 1, 2, 3 and 4. These inhibitors are inhibiting the process of thyroid functions, right. You can see in the top one where the iodides get trapped, right. So, that propylthiouracil and methimazole drugs are there which acts and inhibit that process. When this iodine goes and bind with the thyroglobulin and then it releases out the thyroglobulin, means that this binding with the thyroglobulin is inhibited by, here you see iodides, propylthiouracil and methimazole, here also they act. Once they release into the T4 and T3, their iodides are acting, and at the peripheral tissues, when these hormones are producing its effect, can be controlled or modified by beta blockers, propylthiouracils and methimazole. So, propylthiouracil and methimazoles are almost acting everywhere. So, let us see what are other drugs in the classification. First category is inhibit hormone synthesis, right. So, these drugs are there which are inhibiting hormone synthesis, which we call it as anti-thyroid drugs: propylthiouracil, methimazole and carbimazole. Second is inhibit iodide trapping, ionic inhibitors, for example thiocyanates, perchlorates and nitrates. Third is inhibit hormone release, inhibit iodine iodides of sodium and potassium salts, organic iodides. Fourth one is destroy thyroid tissues. These are the drugs which destroy the thyroid tissues, radioactive iodines, right. 131I, 125 iodine, 123 iodine. Compounds in group 1 and 2 may be collectively called goitrogens. That always keep in mind. Compounds in group 1 and 2 may be collectively called goitrogens. Okay, because they can bring the condition in their high doses or in toxicities, they can bring the condition of hypothyroidism. Other than this classification, we have some more drugs which are directly indirectly acting on the functions of thyroid hormone. Lithium inhibits thyroid hormone release. Amiodarone inhibits peripheral conversion of T4 to T3. Also interferes with thyroid hormone actions. Sulfonamides and para-aminosalicylic acid inhibit thyroglobulin iodination and coupling reactions. Phenobarbital, phenytoin, carbamazepine, rifampin induces metabolic degradation of T4 and T3. You can understand these are the drugs which are also comes under the drug interaction of the thyroid hormone. Another agent which is called it as goitrin, found in plants, especially cabbage, turnip, mustard, is the cause of goiter in cattle who feed on these plants, may contribute to endemic goiter in certain iodine deficient regions. So, first drug what we are going to discuss here, that is the thioamides. Under the thioamides we have methimazole and propylthiouracil. In UK, carbimazole, which is converted to methimazole in vivo, is widely used. Methimazole is of about 10 times more potent than propylthiouracil and is the drug of choice in adults and children. Due to a black box warning about severe hepatitis, propylthiouracil should be reserved for use during the first trimester of pregnancy. In thyroid storm and in those experiencing adverse reactions to methimazole. Here, very important point is that the propylthiouracil is a drug which we should keep it for reserve in the conditions of first trimester of pregnancy in thyroid storm, right, and in those experiencing adverse reaction of methimazole. So, in these conditions, either first trimester of pregnancy, in the case of thyroid storm, in the Patients who are experiencing adverse reactions with methimazole can be used the propylthiouracil. Here you see propylthiouracil, methimazole and carbimazole, their structures. These are the few main difference between the propylthiouracil and carbimazole, right? Dose to dose less potent, the propylthiouracil, while carbimazole about 5 into more potent, means 5 times more potent. Highly plasma protein bound propylthiouracil, while the carbimazole less bound. Same way T half is 1 to 2 hours and the here 6 to 10 hours. Single dose act for 4 to 8 hours, here act 12 to 24 hours. So these are some major differences. Here propylthiouracil also inhibits the peripheral conversion of T4 to T3, while carbimazole does not inhibit T4 to T3 conversion. Propylthiouracil needs in multiple doses, while carbimazole can be given only on single daily doses. So these are the very important differences. Very important to understand these pharmacokinetical differences. In beginning, I have given you a little information. Methimazole is completely absorbed but at variable rates. It is readily accumulated by the thyroid gland and has a volume of distribution similar to that of propylthiouracil. Excretion is slower than with the propylthiouracil. Around 65 to 70% of a dose is recovered in the urine in 48 hours. In contrast, propylthiouracil is rapidly absorbed, reaching peak serum level after 1 hour. The short plasma half-life of these agents has little influence on the duration of the anti-thyroid action. Both thioamide cross the placental barrier and are concentrated by the fetal thyroid. So this is a placental transfer is there. So that a caution must be employed when using these drugs in pregnancy. Because of the risk of fetal hypothyroidism, both thioamides are classified as food and drug administration in the pregnancy category D. Of the two, propylthiouracil is preferable during the first trimester of the pregnancy because it is more strongly protein bound and therefore crosses the placenta less readily. So which one you will prefer? Prefer the propylthiouracil. How it acts? The thioamides acts by multiple mechanisms. The major action is to prevent hormone synthesis by inhibiting the thyroid peroxidase catalyzed reaction and blocking iodine organification. Means the iodine which been trapped and brings inside and binds with the TGP, this all is being inhibited by these thioamides. In addition, they block coupling of the iodotyrosines. So not only the trapping but also the coupling can be blocked. They do not block uptake of iodide by the gland. So they are not blocking the uptake, but the conversion of iodine into iodide, that process blocked, as well as the coupling. Propylthiouracil and methimazole inhibit the peripheral deiodination of T4 and T3. So that is also they do. Peripherally, they are not allowing the T4 to convert into the T3. They have some kind of toxicities. Adverse reactions to the thioamides occurs in 3 to 12% treatment patients. Most reactions occur early, especially nausea and GI distress. In altered sense of taste or smell may occur with methimazole. The most common adverse effect is a maculopapular pruritic rash, at times accompanied by systemic signs such as fever. Rare adverse effects include a urticarial rash, vasculitis, a lupus-like reaction, lymphadenopathy, hypoprothrombinemia, exfoliative dermatitis, polycirrhosis, and acute arthralgia. Cholestatic jaundice is more common with methimazole than propylthiouracil. Asymptomatic elevations in transaminase level can also occur. The most dangerous complication is agranulocytosis, and frequent but potentially fatal adverse reaction. So I hope you understood about the thiamides. Now I'll talk about the another second category, which is anion inhibitors. Monovalent ions such as perchlorate, pertechnetate, and thiocyanate can block uptake of iodide by the gland through competitive inhibition of the iodide transport mechanism. So already I have explained you how the iodide get transported by the sodium co-transporters, and this process has been blocked by these monovalent anions. The major clinical use of potassium perchlorate is to block thyroidal reuptake of iodide in patients with iodide-induced hyperthyroidism. However, potassium perchlorate is rarely used clinically because it is associated with aplastic anemia. Now, next category is the iodides here. So, in this iodides, we'll see the mechanism how they do. Iodides have several actions on the thyroid. They inhibit organification and hormone release and decrease the size and vascularity of the hyperplastic gland. In susceptible individuals, iodide can induce hyperthyroidism, which is also called as Jod-Besidow phenomena, or precipitate hypothyroidism. In pharmacologic doses, more than 6 mg per dl, the major action of iodides is to inhibit hormone release, possibly through inhibition of thyroglobulin proteolysis. Improvement in thyrotoxic symptoms occur rapidly within 2 to 7 days. Clinical uses of iodide. Disadvantages of iodide therapy includes an increase in intraglandular stores of iodine, which may delay onset of thiamide therapy or prevent use of radioactive iodine therapy for several weeks. Iodide should not be used alone because the gland will escape from the iodide block in 2 to 8 weeks, and its withdrawal may produce severe exacerbation of thyrotoxicosis in iodine-enriched gland. Here is one important point to understand that above a certain level, intrathyroidal iodide inhibits organic binding. Then so-called Wolff-Chaikoff effect will be there. After a time, as the thyroidal iodide concentration decreases, intracellular level of iodide falls. Then what will happen? Escape from the Wolff-Chaikoff effect occurs and the hormone synthesis resumes. In some individual, that escape mechanism fails, and then that leading to an iodide-induced goiter. Chronic use of iodides in pregnancy should be avoided since they cross the placenta and can cause fatal goiter. What are the toxicities? Adverse reactions to iodine, called iodism, are uncommon and in most cases reversible upon discontinuance. They include acneiform rash, swollen salivary glands, mucous membrane ulcerations, conjunctivitis, rhinorrhea, drug fever, metallic taste, bleeding disorders, and rarely anaphylactic reactions. Now we'll see the radioactive iodine. So 131 iodine is the only isotope used for treatment of thyrotoxicosis. Administered orally in solution as sodium iodine 131, it is rapidly absorbed, concentrated by the thyroid, and incorporated into storage follicles. Its therapeutic effect depends on emission of beta rays with an effective half-life of 5 days and a penetration range of 400 to 2000 micrometer. Within a few weeks after administration, destruction of the thyroid parenchyma is evidenced by epithelial swelling and necrosis, follicular disruption, edema, and
leukocyte infiltration will be there. Advantages of radioiodine includes easy administration, effectiveness, low expense, and absence of pain. Radioactive iodine should not be administered to pregnant women or nursing mothers since it crosses the placenta to destroy the fetal thyroid gland and is excreted in breast milk. So you have seen these most directly acting drugs here, radioactive iodine, and you have seen the iodides, and you have seen the propylthiouracil, methimazole, and carbimazole. Other than that, there are certain drugs which are indirectly act to improve the symptoms of these particular diseases. Under that, we have adrenoceptor blocking agents. Propranolol has been the beta blocker most widely studied and used in therapy of thyrotoxicosis. Beta blockers cause clinical improvement of hyperthyroid symptoms but do not typically alter thyroid hormone level. So they are not changing the thyroid hormone level but their functions. Propranolol at dose greater than 160 mg per day may also reduce T3 levels approximately 20% by inhibiting the peripheral conversion of T4 to T3. This one table was there. I don't know how much clear it is. It was a summary of all these drugs. You can see the class of drugs have been given this side. Their mechanism, their indications, and pharmacokinetic toxicities are there. This table you can find in the book Katzen. From there I have drawn it. Here are some assignments for you. Assignments looks a little more, but it's very important if you go through with this, because once in a while you will receive the short notes on it, or maybe you will have the questions here and there about these things. One is the management of hypothyroidism. Already the drugs and other things I've explained, just you make it a one separate note for the management of hypothyroidism. Special problems in management of hypothyroidism, right? So under that there are a few problems which are special problems considered in hypothyroidism and how to treat them. For example, myxedema and coronary artery disease, myxedema coma, hypothyroidism and pregnancy, subclinical hypothyroidism, drug induced hypothyroidism. Also management of Graves' disease, management of toxic uninodular goiter and toxic multinodular goiter, management of subacute thyroiditis, management of special problems. For example, thyroid storm, ophthalmopathy, dermopathy, thyrotoxicosis during pregnancy, neonatal Graves' disease, amiodarone-induced thyrotoxicosis, and non-toxic goiter, thyroid neoplasms. So these are the assignments I expect from you all to, these are given in the books, you can find out and make a note with you. So I hope by this you have understood well that what the thyroid hormones are and what are their roles in the physiology, and the drugs which are blocking the effects of the hyper conditions of the gland and to inhibit the hormones, right? So these are the references. For all the references are used for some material inside what I have taken. The diagrams are from all the books I have referred. So thank you all for watching this video, and I hope you can revise this video again and again so you will get a clarity for the thyroid hormones and its pharmacology. Thank you everyone.